Okay, we're talking about OneDrill. All of you, many of you in the 50, you probably doing a lab, and they give you a little fake mannequin jaw, and you try to drill, and they give you a surgical kit, and you pick up one drill, and you slowly looking at the lines, be careful, and second drill, third drill, right? Okay, what I'm going to say is one drill, and many people are going to think one drill is like impossible. Why? Because one drill. How are you going to do one drill, and you're going to pick a big fantasy drill and just jam it right in and burn the bone and put an implant? Yeah, that's what most people think. Okay. No, drill. What other word put this in Chinese, but I'll kind of explain to you. Why some company takes 4 drills to do one implant, some company takes 10 drills to do one implant. I don't know why. That's a company. Okay. Why some drill is easy to drill, some drill is really difficult. Some drill does look sharp, really sharp, but doesn't cut. Okay. Why some drill bounce so much? Okay, this is all the common question people ask. Why there are some drill are so funny thing. Do you know when the drill is dull? I asked a lot of doctors. Do you know when the drill is dull? No, I don't know. So when do you know it's dull? In the middle of surgery. If I'm a patient and knowing that you putting a dull drill and found out like this is a drill you're going to change it in the middle of surgery, but that's the truth. That's the truth. It's unspoken, naked truth. We don't know when the drill. The company said, okay, you only use 20 times. How many times we really count 20? Now, some drill we probably the nurse you tell the nurse throw this away. It's very dull. Nurse went back, slowly sterilize it and give it back to you. You open it. I told you this is dull. Throw away, and he's still going to come back to you again, right? So when do you know the drill is dull? You don't know only on the middle of surgery. So many difficult. How do we prevent the drill from burning? When I say one drill, people think it's a mini implant. Yeah, mini implant is one drill. You just drill an implant and then screw the implant in. One drill. No, I'm talking about regular implants. Regular size. Can you do it in one drill? Okay. This patent, I got a #1 award in 2015 in Pittsburgh. Nick was there. There's a Nick. We even got some money from that check. But anyway, they were shocked. It was being invented. I'm going to share with you. This is one drill. This drill, we use it, and then you can pretty much disposable, throw away if you want. And then the implant goes in. That's it. The drill has a stopper right here. So it doesn't matter how hard you push, it stops at that stopper. So you don't need to look for the markings anymore. You know, when we do drill, we always look at the markings because we want to make sure we don't over drill or under drill, right? But tell me the truth. Patient has saliva, has water, is bleeding. Can you see those markings? Most of the time we don't see it, we're just guessing it. Right? And you tell the assistant, suck it up, suck faster, I can't see the line. So you're wasting a lot of time just talking to each other, contaminating the mouth. Okay, so this is a conventional, traditional way of drill. You get a purchase point, you go wider, and there's a marking, wider, and here's the implant. So we're gonna do one drill. By the time this doctor does the second drill, I finish my implant. So by the time this doctor finish one drill, I finished 5 implants already. If we're doing multiple implants. Okay, how do I think of it? How does one drill work? A lot of people think, well, you must skip something. No, I did not skip anything. I cannot skip anything. Look, this is for example, first drill, second drill, third, they get wider and wider, right? So this one is first drill, second, third, they get wider and wider. So if I put this 4 drill, when I turn it around, I did not skip 1, 2, 3, 4 drills. But if I turn it around, does it look like the one drill? So did I burn any bone? No, I did not burn any bone. As I go in first step, I was in this drill. Second step, I was in this drill. Third step, fourth step. So I can slowly, I don't need to change this drill anymore. I can slowly just go one step at a time. While the other doctor changing the drill, wasting every minute changing the drill, I'm just concentrating one step at a time. And then after that, implant, because this goes a step configuration, and the implant is the cylinder configuration. Okay? So let's look at it. The first is initial drill. When you pass this drill, it bounces. It will bounce. First drill usually bounce. Anyway, it doesn't matter, conventional or OneDrill. It bounces a little bit, but once you pass it, it became a drill guide. It doesn't bounce anymore. It smoothly just guides you down to second drill, third, fourth, countersink stops right here. So you finish all the drills in one drill. Okay, let's look at this. Nina sent me this picture, Nick sent me this picture last year. I went back and I found out my picture back in 1991. I was concentrating so carefully on the markings. Learned my first implant in the lab. I asked Nick, what are you looking at? Looking at the lines. I look at Nina, what are you looking at? 30 years later, we're still doing this. Come on. We're still doing this. Are we changing anything? Nothing. Actually, I was much more advanced. Why? I have even an instrument to stabilize my jaw. You don't have instrument to stabilize your jaw. Come on, you are behind. But what I'm saying is we are still doing the same thing, changing drill after drill. This is her little sister. I gave her one drill. She doesn't even know what she's doing. She just kind of punch it in. She's done with her 10 drills. I gave her the implant now. She look at her foot pad, make sure she's stepping on the right foot pad. She places the implant. To her, it's toy. To us, was like life and death. Why is that? Can implant become a toy? If we treat implants as a toy, everything becomes simple, easy. You know what she did? In 5 minutes, she did 5 holes. She did 5 osteotomy. The space pretty good. Did not perfect to the buccal or lingual. Why? Is she better? No, she's not better. I'm not insulting any implantologist. I'm saying instruments is simple. Why? Because it doesn't matter how hard you push down, it stops right here. So you predetermine what size, what the length of implant you want. You predetermine the length because you look at CT, so you know. So you pick up that drill for that size. You just place it, and it stops right here. It doesn't matter how far you push, how hard you push. That's it. Done. Place the implants. Now I'm trying to come up with this become disposable because this one is new, so it's always sharp, never been dull. So open our package, throw away, put the implants mouth, this goes sterilization. We're done. The instruments is so simple. So if I say we're going to do 5 implants, how simple can that be? Can it be just walk in and walk out? Yes. I want to treat implant as we do in the filling. When you do filling, do you tell the patient, say, wait. I schedule you a month later. I need to take a CT. I need to talk to all my colleagues about this filling. I don't think anybody does that, right? Filling, come in, yeah, let's do it now. Implant is simple. Come in, do it just now. There's one area that needs an implant. I pick up I predetermine the length of the drill. I go in slowly, 1 step, 2nd step, 3 step, 4 step. I did not change out any drill. Then implant goes in, done. 3 months, restored. How much pain did I cause this patient? I have even a patient say, did you do implants on me? I said, yeah, I pay you so much. I don't think you did implant on me. I said, when I look at x-ray, I have to show them the x-ray. Oh, okay, I guess.
This patient is a 51-year-old male. His previous implant was from a different dentist and manufacturer, which failed. Dr. Chen used his newly invented implant system to treat this patient.
Using his 25 years of implant experience and knowledge, Dr. Chen patented this implant system, called the OsseoFuse Dental Implant System. with the hope that other dentists would also adopt this system
Now look at
to
the
reduce or
timer.
eliminate further implant
It's a real time.
failures.
OsseoFuse dental implant system. 1 drill, 1 abutment, and 1 kit. In this surgery, Dr. Chen is using only a 10 millimeter step drill to place the implant in that patient's left upper jaw. He then places a 5.25 millimeter implant and connects it with the abutment. It's as simple as that.
The following surgery shows the patient before and after the surgery.
This
50
surgery
seconds.
took nearly 50 seconds before the anesthetic wore off. The patient could eat or drink anything he wanted to. This is the patient's remark about the surgery. This surgery completely changed my perception about the dental implant experience.
50 seconds. We do 1 implant. How simple can that be? And then some people say, no, can you go fast? Can you go faster? I think that's enough. 50 seconds is pretty short. Okay, am I doing the less implant? No. Actually, if you look at Osteum, is a Korean brand. They're doing a surgical stent. Takes 4 drills to do implant. They're bragging. Oh, we takes only 4 drill. Then Deal takes 10 drill to place 1 implant. And Magazine takes 12 drills to do 1 implant. Which one do you want to do it? You want to use the same implant, same kind of implant. Why? I think you'll pick 4, takes 4 less drill. So if somebody with 1 drill, which one will you pick? 1 drill. It's just simple as that. Now you look at it. How about the bigger company? Are they doing this? Yes. In Madrid, 2 years ago, Nobel came out with 2 drill system. Okay? I came out with 1 drill in 2012. And Nobel came out with 2 drill 2 years ago. They have a direct drill. I don't know what that is. That's just the same drill, just a drill. And then you have shaper and there's an implant. Okay? So the trend is going that direction. But already we have 1 drill. So why do 2 drill? Okay? Now, Straumann, they came out with 2 drill too, just recently. But just think, Nobel's final drill looks very aggressive. Look at Straumann. Their final drill is not implant. Their final drill is the implant. It's the implant, not the drill. The implant looks aggressive. Aggressive is not good. Why? You may cut the nerve or cut the artery. So, but they want to go toward that direction too, which means less drill. Let's look at it, why my concept of an implant does work. When you do the first drill, you're creating a bone with the steps, right? So the implant goes in. Now, in the implant, we have inner body. What that means is a solid body of the implant. The outer body means include the thread. That's the outer body, isn't it? So, here. Okay, that's the outer body. Include the thread. That's what we call the outer body. So let's look at it closer. So, the inner body of the implant do not touch the bone at all. So will not cause bone necrosis, compression necrosis. So what locks this implant to the bone is the outer body, which is the threads. Okay? And why? Because a thread, if you think of it before, this is over drill, under drill, over drill, under drill, because it was a stepped configuration, right? And the over drill part is where the thread comes in, cut off the under drill bone powder and push it, relieves it to the over drill area. So the under drill area gets the locking and the over drill area gets the pressure release. Do you kind of get it maybe a little bit? So anyway, so excessive autogenic bone will get pushed to the over drill area. So the entire thing is completely locked plus relief at the same time. So there's no pressure necrosis. Okay? How strong, how much the stability, primary stability is? This is immediate implant. We take the implant out, we take a tooth out, put an implant in. Okay? We place 2 implants. You know how much torque that is? That's over 70 Newton centimeter. With a huge hole like this, I was able to place the implant and gets locked 70 Newton centimeter. That's really stable. If that's the case, then we can finish it. the final. Not yet. This is a temporary. But I am going to that direction. I'm writing an article, how to do implants all in one day, final, finish. Don't come back, you're done. Okay, that's what patient wants, right? Patient want a tooth, don't want to wait 3 months, they don't want 5 surgery, year and a half. Okay, let me just go this quickly. I think, or we're gonna take a little break. You okay?
Yeah.
All right.
Want to take a break?
Take a break?
100%.
All right. See, this drill, because it has steps, so what the drill can drill do, change the angulation. Because the steps. The step give you side cut. So now today,
不太觉得不太确定，再一次支持下去，那这knife edge 这个就
okay. So you go from the side, and then you can redirect the angle because the thread has a side cut capability. Okay? So if, for example, today you have a knife edge, if you go straight, it will bounce off to left or right. So you go to the side and then change the angulation and you go straight up. Okay? Let's look at this. Let's say you have an L-shaped wall. L-shape means like so much buccal bone loss. There's no more buccal bone. Okay?
看到像这个洞在中间嘛，哈，
But I want to place right in the middle.
你要先侧的，
So still, instead of going straight down, you go sideways so the bird doesn't bounce. And then once you go 1 or 2 steps, then you start to redirect the drill to exactly where you want. So this is an L-shaped bone. You're able to place the implant right
有
there.
没有？
Okay, for example, this is one of my doctor, he did this. The implant was, you think it's exposed. No, actually it's right embedded in the L shape, and he just grabbed the bone and close it up. That's it. So advantage of this drill, it can change the angle. Let me share with you the real life. See, when I go straight, it bounces around too much. So then I just go from the side. And as once you get 1 or 2 steps in, doesn't bounce anymore, I start pushing it toward the middle. So now I straighten it. Okay, so it was from this direction and coming to this direction and go down. Okay, so with the multiple drill, you know what do they do? Change the angle. As they change the size of the drill, they change the angulation. But that takes too much time. Just do it right here. You just one drill and you change the angle. Where do you want and go down further? Okay. Now, can the implant change the angulation? Yes. But let me just skip this one. Anyway, I'll just skip. Now we do the immediate implant. I'll share with you the immediate implant. Okay. The timer is on now. So I took the tooth out. There's a real timer, no edit. Okay, so it took me that long to take one tooth out. But then you still have to clean it because it's infected tooth, right? The socket needs to be clean. So you scrape it clean. It takes a while to clean it. Okay, now after cleaning, I'm going to drill a osteotomy. So because this is only one drill, so I just drill one time. Takes probably only 10 seconds to drill that osteotomy. So I didn't really rushing it, it's a real time, okay? But it's only less than a minute still. Now, I changed to implant now. So there's no edit, no cutting, it's just straight right to the video. So I kind of share with you the implant design, it looks like a propeller. Looks like propeller. See, when I step on it, you can see it looks like a propeller. So it bites really nice to the bone. Okay, so when we do immediate implants, we want this implant to be primary stability. So immediate implants, all done. 1 minute and probably 40 seconds. Okay? And this is what we took this tooth out. Immediately we place one implant in within 1 minute and 34 seconds. Okay, now we're going to talk about the kit. You probably think the kit is nothing. Kit meant a lot. Let me share with you. If you go to Straumann and say, hey, I want to learn how to do your implants. Okay, good. And I want to do two-piece implants. Oh, yeah, here. They give you a surgical kit with two-piece implants. Then later you say, hey, I want to do one-piece implant. I'm not sure you know what's two-piece or one-piece. Two-piece implant means an implant and abutment there and two separate. And then one piece means they're all in one piece, one body. Okay. So then if you tell a Straumann and say, hey, I want to know how to do one-piece implant. Oh, sure. We have one-piece implant. It's a new surgical kit. Different surgical kit. Then you're going to say, oh, do you have a white implant, zirconia implant? They'll say, yes, we do. Called Pure. Okay, nice name, Pure. I want one, yeah. Buy another surgical kit. You know why? I don't know why, but I can tell you the reason. Because the company is so big, they want to have everything. So whatever you want, I will provide. True, it's good. But why in same company you give me 3 different surgical kits? Because he went and bought a small company who has one-piece implant, as it were here. But for us as an operator, it's too complicated. For nurse, it's too complicated. Every time you want to do implants, the nurse say, what brand? XYZ. What kind of two-piece, one-piece, or zirconia? Why? I have to prepare a different surgical kit for you. All right? So for OsseoFuse, you have two-piece implant. These are two-piece implant, one-piece implant, zirconia implant, sinus implant, all in one surgical kit. So everything I do, you know why I came up with this idea? Because I ran into a problem one time. In the United States, when I do zirconia implant, I charge extra $1,000. So I told the patient, hey, in the front teeth, zirconia looks pretty better. You should get white zirconia. No, too expensive. You're already too expensive, Dr. Chen. Another $1,000, that's too much. So as I drill a hole there, and before I place the implants, she grabbed my hand. She said, after I thought of it, $1,000 still now. No, I'll do zirconia. And I looked at the patient. Why didn't you tell me earlier? This hole that I just drilled doesn't fit the zirconia. Right? So that's when I decided I need to invent something that one surgical kit, you can do anything you want. Any last minute change, I still can do anything you want. Okay? And it's easier for us, easier for the nurse. Let's look at zirconia. Today I'm going to do an extraction on this tooth. I think this one. Let me see. Yeah. Okay. This is 2 times faster. The entire surgery takes an hour and a half. A minute and a half. So it's about 40 seconds now. I just kind of make it double the timing. So it's about 40 seconds. You can see this. Okay. I prepare my site. I took the tooth out, prepared. Now I'm going to put a zirconia implant. This is the future. Zirconia implant is the future. Why? It's not because they're beautiful. Yeah, they're beautiful because they're white. Zirconia material do not give us a bone or soft tissue any information. So whenever you place the implant, the gum just looks exactly beautiful the day you put the implants in. It doesn't look red and then pink. It doesn't turn red and pink. It just pink from the day one. Okay? So I finished. And patient liked it, so she wants the other side done. So again, another minute and a half.
Also the smell.
Hmm?
The smell.
Smell?
Zirconia versus titanium.
Oh, titanium does smell, yeah. When you have a titanium patient, when they talk, they have this metallic smell. Okay. Then OneDrill, we're done. Now I'm gonna put one in zirconia implant in. So 1.5 minutes. So in 3 minutes I did 2 implants on her. So I told a lot of doctors, say, my patient's so addicted to implants, a lot of doctors do not believe me. You just photoed it, No, if you think if I could do one implant minute and a half, you think people decide to do a root canal? If I give a patient the option, you can have root canal or you can have implant. Or I should not say root canal, redo root canal or epicolectomy versus implant. I think patients say, oh, just give me implant. I have so many patients came to me to say, don't give me root canal, just give me implant. It's faster, quicker. Okay, now let's talk about one platform. The platform is important, but I want to share with you because this is something you need to know. I just kind of pull out all different brands. It doesn't matter if all the brands are the same. They're the same. Let's look at this brand. If you use the 3.0 millimeter implant, the abutment is different size. It's smaller abutment. When you go to wider implant, the abutment goes wider. So it is very complicated. Why? Because if I do implant here, I need to keep the record because I need to know that abutment size. Okay, that's too complicated. Well, let's look at another implant. Same thing here. This one. The abutment size is different. Okay, so what I would like to see it happen is, but that's not it. Wait. Let me just think of the logic behind it. This company, I don't want to say what company that is. He has 3.0. Beside the abutment, they have the width of the implant, 3.0. 3.5. So what's 3.0 to 3.5? It's 0.5. So what's 3.5 to 4.3? That's 0.8 increment. I said, well, 0.5, 0.8. 4.5 to 5, 0.5, 0.8, 0.7. What are you thinking? Okay. Next one, 2.0. What's the logic behind this? No logic. I asked so many companies. I went to, tell me, why do you have this incrementation? Oh, it's a pattern. No. There's no pattern here. Oh, because my famous professor say this is the best size. No. Patient's bone is the best size, not your professor. Okay, let's look at this one. 3.9. I asked, what's different 3.9 and 4.0? Oh, it's a pattern, so we cannot touch 4.0, so we do 3.9. Okay, what's the logic behind this to that incrementation, 0.4? What's this to that? 0.7. No logic. So you look at any system, just no logic of the incrementation. Plus the abutment are different too. Okay, so what I'm sharing with you is this. I decided if I invent an implant system, I want one platform. What that means is, doesn't matter what I put in underground. When it comes out, the neck is the same. The neck is the same size. Okay? What that makes better, because I can put super fat implant in the front, I still have a little skinny neck for my incisor. So it's just, doesn't matter what's down there. What comes out is same size. Simplified, very simplified. Okay? Look at this case. Immediate implant, I place the implant. Because the implant has such a strong stability, I place a wider abutment. This is a healing abutment, wider. But the neck part is the same size, just wider, like a flower. Imagine this. This is what you think is. From here, to most of us, surgeon would be one surgery already. 3 months later, bone graft. Then 3 more months later, implant. Then 4 more months later, then healing. Look at this. From here to here, all in one surgery. I did not suture that area. I did not do any bone graft in that area. Now look at the gum. That's a healthy gum. I did not do any bone graft. I took this tooth out. I placed the implant. All healed. The bone naturally grow. So one surgery, 1 week later, I see the gum looks really nice. Look at the gum. 4 months later, looks very healthy. Okay, one surgery, that's it. Front teeth, I'll just go quickly. We'll take the teeth immediately, 4 implants, finish in the front teeth area. Because front teeth, the people think the aesthetic reason. This kid has a motorcycle accident, same teeth, fracture of the front teeth, 3 teeth, immediately give him a temporary teeth because he wanted to go to school. He's still dating a girl. So he doesn't want to walk around like this. So he flew in, get this done. At least the girlfriend doesn't know what happened. 4 months later. Okay? So what we're doing is service for the patient. Get it done in 1 visit. People say I charge a lot. Yes, I charge a lot because I save a lot of surgeries on you. I save a lot of pain, right? This is what you are facing right now. A lot of doctors like to show you how to harvest a bone from a ramus, getting a piece of bone. And for example, the ridge is so thin, they put a block of graft from the ramus and they pin it. This is not implant. They do this little screw pin to stabilize this block. Then bone graft. They all look very nice. Do you want to be this patient? How many, you think this patient going to refer her husband to you? No. We are out there trying to make money, make living, right? But this is the common practice right now. Can we do this in 1 visit? Yeah, look at this doctor. I shared with you before. Immediately extract, place 3 implants, bone graft, all in 1 visit. 8 months later, he uncovered, you can see all the bone grew back. You can see on the CT, all these are just grafted bone. Just 1 visit. Would you rather do this or do ramus graft? Let me share it with you, because the ramus graft, you probably think it's really cool. You have to understand ramus graft speakers. I've been with them 30 years ago. That speaker, that group of speakers, they first get bone from here, from the hip. And then about 2 years later, start lecturing, getting a bone from a chin. About 5 years later, they start speaking, getting a block from ramus. Then I said, we were good friends. I don't do that. I was good friend. I usually laugh with them, joking with them. Hey, let's have beer, let's have cocktail. So you took a bone from a hip. Yeah. So what did you put back in there? Artificial bone. Also, the hip is not important, huh? You put artificial bone. Why not artificial bone? Right in. No. Hip bone is better. Okay. So now you took the hip bone. Now why you change your mind to chin? Oh, chin bone is better. Okay, so now why you change to ramus bone? Oh, ramus bone is better. Bone is bone. Come on. When you take the bone out of your body, 30 minutes, this bone has no more protein. It's just synthetic powder, same. Remember that. There's no more protein in there, no more growth protein anymore. Okay, so anyway, I just need to share with you. Now, let me just, what if implant fail? A lot of people are so scared about implant fail. Wow, implant fail, it's going to be a big trouble. Oh my God, the hell is coming. No, I need to tell you, when implant fail, to me, it's just regular practice. I don't get surprised. Okay, just come on, let's do it again. But traditionally, when the implant did not get integrated, we take the implant out. We tell the patient we need to wait a few months for the bone to the socket to heal. We need to do 3 months later, we'll do bone graft. And we redo the implant for you for free, mister. You know what that Mr. Jones gonna say? Forget it. You're lucky I didn't sue you. Forget it, I don't want implant anymore. Yeah, because you never practice, you don't know. When you go out there in the real life, patient will say, give me the refund. Forget it, this area, just bridge it. Or I can live without it. Okay? So you lost business. So how do I do differently? You love me after this. Remember I mentioned to you the diameter of the implants. The OsseoFuse diameter is 3.75. The incrementation is 0.75. The incrementation again is 0.75. But then you're going to say, wait, but your next incrementation is 6.0. Why not 6.5 now? I found out, I'll tell you why. But there's logic why I make these sizes. Not because of patent, there's logic to it, okay? This is my small, medium, large, extra large, XXL. And there's another XL. X small here is 3.0. Why do I make this logic? perfect because I start realize whenever you place the green 375, if the implant failed, did not get integrated, you clean it. You don't need a drill. No more drill. Just clean it. Go 2 sides up. I guarantee it locks it. Locks it right in. So you can numb the patient. Tell the patient, hey, I'm sorry, this implant got infected, but I'll fix it right now. What the patient gonna say no? Oh, yeah, please fix it. It's infected, right? Yeah. You gonna charge more? No. But what happened? I changed out the implant. What do you need to tell the patient you change out the implant? But even patients say you change out the implant. Yeah, it changed. It's good now. Okay? So you skip 2. Now if this one fail, it goes to that. So I found out 6.0 do not get locked. Did not get this size to get locked. Once it gets bigger and bigger, the diameter gets wider. So instead of a 6.0, the incrementation went to 6.5. This one saved him. And this one will save him. So one time I had this doctor, he is one of the biggest banker in Taiwan. Nothing can go wrong. I did 2 implants on him. And when patient come back for follow-up, I tap. It sounds really crisp, really solid. Tap. The second one, I was like, I didn't know what to tell him. This implant didn't work. So then I said, he looked at me and said, why does it sound different? I said, yeah, it's different. Let me tighten up more for you. Oh, okay. So I numb him up. I said, let me tighten up. You know what I did? I changed out the implant. And when I changed out the implant, cap. Next one, cap. He looked at me like, they sound the same. So yeah, I tightened up for you already. Did I lie to patient? No. Patient wants is a good 2 implant that he paid for it, right? So why implant failed? You have to face it. It may fail. Today there's one immediate implant here. I took it out and placed implant 3.75. It looks really good. I gave him a final crown here. She went home 2 weeks later. She came back. Failed. So I quickly changed to this size. Look, a little wider now. I gave her another temporary. It looks the same. So she came in for follow-up. I gave her another temporary. She didn't know what happened. I just said, hey, you have a little infection. I need to clean it up for you. Okay. Now, with the wider implants, you think the papilla gonna look a little different? No. The papilla gonna look very nice as others. Why? Because the neck is one size. Remember I told you, neck is one size. So it doesn't matter the base is skinny or wide or fat. The neck is one size. So it comes out incisor, lateral, premolar, molar. That depends on you. What do you want? Right? So it doesn't affect any of the gum around it. Right? I did all this implant, looks really good, happy, patient think I'm great. So somehow when I was tapping here, sound different. So I know something there. So I told the patient, hey, I need to numb you a little bit. So I don't face the failure as, oh my God, I failed. No, just fix it. You're gonna face that anyway. So as I unscrew this heating, listen to that. Most doctors, when I saw this, they fainted. When I saw this, I love that sound. It's like suction. Why? Because I know how to fix it. Okay, so what we did is, this one failed goes there. This one failed goes there. So that this one was the blue. So now I had to clean it up. Of course you have to clean it up. Don't need to drill again. If you drill, patient gonna feel, oh, you redo my implant. That's a different concept now, right? So I said, hey, you have a little infection. I'm going to clean the infection for you. So you're going to hear some scraping noise. That makes sense, yeah. Okay. Then after I clean the infection out, I did not drill. I picked up a drill, but no handpiece. Just pick up a drill to try to fit it. If you feel a little friction, perfect. That's a perfect for the implant, for that size. Okay, I just want to double check. So I went ahead, just kind of feel that osteotomy has a little friction, little resistance. Good. So I pick up the size, double the size. Remember, the platform is same size anyway, so it doesn't matter. So I placed another implant here. I took it out, same time put it in. Then patient asks, what are you doing? Well, I'm not drilling, I'm just make that implant tighter for you. Okay, right? If you pull out the motor and hand piece and with all the gears, then patient knew, fail. You are doing redo another implant here, right? Okay, so you know how tight that is? Look at the torque. It should be like more than 80. Look at all the way to the end. That's 80 Newton centimeter. So did we finish this implant? Unnoticeably, we finished the whole mouth. Patient did not know had one implant failed. That's what we do, right? So when people say, you have any failure? I say, no, I never had failure. Never. My failure means that patient did not want to come back. That's a failure. Okay, this is just ongoing. Now I finished, so no failure. To me, it's no failure. Now, listen to it. Sounds pretty good now. Patient agree? I agree. Okay, go home. Any bleeding? None. Okay. Okay, now we talk about immediate implants. People probably think of immediate implants is no. I practice 100% immediate implant. 100%. Everybody walk in immediate. Why? Eventually, you know what I'm going to tell you. Many times you tell the patient, say, this tooth, we need to pull it out. Go home, we need to wait until the socket heal, and we'll do implants. You know, 50% of time patient will call you and say, I decided not to have implants. You say, darn it, I spent 2 hours talking to you, explain to you about implants, I have all the animation, show you everything about implant, you agree, you even give a deposit and you don't want it? No, I decided I don't want it anymore. So do immediate implants. It will help you because the moment patient has pain, he wants it there. Okay? But many implants do not allow immediate implants. All the implant design do not allow immediate implants. Why? Their thread are passive, not active, passive. So they want you to grow the bone first, then the thread can lock it. Okay? So that's the problem. It's not because we cannot do immediate implant. Our skill, we can. It's just the design of the implants do not allow immediate. Okay? Now, let's look at a surface. All the implant has claimed they have the best surface treatment, all the designer brand, best surface treatment. To me, it doesn't matter. Because all the surface treatment is just rough the surface, that's all. One more time, I'll tell you what's a surface treatment. There's a funny story on that too. I know all the implant funny stories. I even know who dates who and had an extra wife, extra baby, or the speaker with someone. I pretty much know everybody. Anyway, let's look at this. There's a curve you're gonna know. This is a table that everybody knows. It's called primary stability curve and a secondary stability curve. And implant once placed in 3 to 4 weeks is the weakest. The implant weakest point was 3 to 4 weeks. Then the secondary, which is not mechanical. Mechanical is a primary, locks it, he bites it. Then secondary means chemical, means biology. The bone cells start grow wrap around it. So you have a surface treatment, which is a bone cell. The secondary kicks in. So now, all these companies are doing what? Secondary stability. They are pushing the curve to this direction. Okay, what that means is usually in 3 or 4 weeks is weakest. Now it's in the 2 weeks, in second week of the implant is the weakest because we push the secondary stability by bone morphology to this direction, right? But it's enough. I think it's enough. Why? Because if you push the bone to grow faster and faster, you know what cell grow the fastest? Cancer cell. So we cannot push this too much. You will push too much, then what happens? It's a cancer cell. Now, cancer cell is fine. You know how to turn on? Do you know when to turn off? If you don't know how to turn off, then it's in trouble. You will grow like the astosis, tori, right? So I think it's enough. So why I decided to invent OsseoFuse? I push the mechanical curve, which is a primary stability curve, to that direction. If I can get stronger bite to that direction, do I get a straight line? So if I get a straight line, can I place the implant and final restoration right away? Yes, I can, because it's straight line now. There's no dip. Am I make any sense to anyone? Okay, so you're gonna remember this curve. Okay, there's a curve of a typical curve. So now we look back. That's just guessing. This doctor does this 4 implant, looks very nice. Why did he do this crooked one here? Do you know the reason? I know. Every time I look at this, I will call that doctor. Did you do immediate here? How did you know I did immediate? You know, you did not see my record, my patient record. How do you know? Well, because you try to reach primary stability, you cannot. So instead of you taking this tooth out, number 6 had 2 roots, you just went ahead and find one root that has a stable for your implant. But that root usually is not in the right direction anyway, right position anyway. Are you following me? So now if you look at this, you can just call that doctor and say, hey, did you do this one immediate? Doctor said, you were not there. Are you a ghost? How do you know I did immediate? Yes. Why? Because we are trying to reach stability. So this tooth implant is on the heel bone, right? But this one was immediate. So the problem is, whenever we do immediate, the implant always not in the right position or angulation. His angulation was good, but his position one is wrong. Which one? This one. So I call him, hey, did you do this immediate? Let me see your x-ray. He sent me the x-ray. Oh, why this one is in good angulation but it's in wrong position? Because it kind of slide right to that socket. Okay, so can you tell which one is immediate? They all immediate. With OsseoFuse, they all immediate. Because remember I said, we can change the angle. We can redirect with the burr and the implant. So they all immediate, but they are all in very nice angulation and position. That was before. They're all immediate, most of them. Okay, well anyway, so primary stability is very important. So if we take the tooth out, this implant is complete. Look, this implant is this much exposed outside the bone, still can reach 14 Newton centimeter. That's how strong the OsseoFuse can get the bite. So if you get a strong bite, can you make a fixed temporary? Patient hates removable denture. You know that. Well, and plus if we do removable denture for temporary, you know what happens to the removable? It press against the bone graft that you did. So it just, all the bone graft that you did, you just compress it down. It all disappear. So it's better to get a good bite, get a good stability, we can make a fixed temporary. So nothing from the outside externally compressed against it. Okay, let me just go a little faster. See, look at this one, immediate extraction 2 implants, and they all torque over 70. Because both socket we can torque over 70, we can go ahead and temporize it, fixed right away. Okay? Let me just go faster on this one. There's nothing. Yeah, same thing. The period, completely all period. I took everything out. One visit, sinus lift, everything, implants all done with the temporary. So she walk in with teeth, walk out with teeth. Then you're gonna say, wait a minute, did you do any navigation, any surgical guide? Did you take any kind of treatment model, study model? No. You come in with teeth, I take impression, you walk out with a stronger teeth, with the impression I just took for you. You came in like this, you walk out with little bleeding. And then zirconia abutment, and after we finish. So from here to here, it takes about probably, I think, 6 months. I think 6 months. All done. Okay? Now, let me just look at the timing. This patient walked in 2:30 in the afternoon. Talking to him, give him all the treatment plan, cost, credit card, all this consent form, plus 4 implants. At 4 o'clock, he walked out. This is the first time I visited him. First time he came to my office, he said, these 3 implants, he feel very uncomfortable, was done somewhere else. He wants these 3 changed out. And I asked, well, how long does it take you to do these 3 implants? He said it took 3.5 years. Still not done yet. Even though it's cheaper implant, still, he doesn't want it anymore. An hour and a half, I finished everything for him. But when I say hour and a half, means he walk in, take an x-ray, go to the bathroom, we have a cup of coffee, we start talking, consultation, credit card, go through, sign, what? All that included, okay? That's what I call them. Walk in, immediate ideal position implant. Anyway, ideal position, immediate implant. Walk in, ideal position, immediate implant. Because it's all nice position. And 4 months later, another thing I call ER time. I'm going to write an article about this ER time. ER time means extraction to restoration time. This is very important. Why? Because traditionally, if you do implant and the patient say, hey, what is your ER time? What's the extraction to the final restoration? Say, about 1.5 years. You think that patient going to continue with it? No, I don't want an implant. 1.5 years? How many surgeries? About 4. So this is 1 surgery, ER time, 4 months finish. Okay, this patient, about 2:30 walked in. What I'm telling you is all true story. He walked in, he flew in from Hong Kong. He walked in and said, I want an implant. That's it. That's all he said. So okay, consent form, everything we signed. At 5:45, he walked out with some teeth. He walked in with only 2 canines. He walked out with something that he can even just smile about. We finished 1 bottle of whiskey. Because he was my last patient, and he came here just for implant, and next day he's flying back to Hong Kong. So we finished a bottle of whiskey. But that's how simple that is. How many Novocaine? 3 carbules. 3 carbules Novocaine. How much risk do we have this involving 3 carbules? Really, nearly none. You know, every carbule is 10 carbules. That's very dangerous, right? So this is 3 carbules. Okay, that was him. Implant, that's okay, just bone graft, everything all done. And we finished. He came back, ER time 6 months. He came back 6 months till we finished. Okay? So let's just go to, this is one of my friends. He learned how to do, I taught him to do the sinus OsseoFuse. 2 months later, he did this 4 months. So that's why I want to encourage all of you, okay? What I'm encouraging is pretty much like something like this doesn't need to take an expert implant guru to do it. This guy is not even an implant guru. He's just a regular dentist. He came and said, teach me how to do implants. I said, well, then use OsseoFuse and I'll teach you how to do it. 2 months later, he did this case. I was so proud of him. He did it in 1 surgery. This woman was drug addict. So he just, drug just pretty much chemical burn. Pretty much all, now, she got married. That's a big change, big difference. Okay, that's what I'm saying. It's very simple.